Rough, man.
Anyways,
All right. So this is the anatomically correct heart. We're gonna start strong,
Yeah.
guys. Okay. So up here, whoops. Come on. All right. So up here is the sinoatrial node. Okay. I'm gonna label it SA. Can you see it?
Yeah.
yes.
All right. Good. And this is the AV node. All right. Do you guys remember what the AV node does?
Nope.
No. Okay.
Backs
So
up the SA node. Make sure your heart beats at what is it, like roughly 80 or 60 beats a
so
minute
the
if the SA
sinoatrial
fails?
node. The sinoatrial node is what sets the pacemaker. And the AV node is what gives it a pause so that the atrium can contract first. So it'll hold the signal and then shoot it down to the ventricles. And how it'll do that is through the Purkinje fibers. Okay. So we have a right bundle branch. Okay. So this is the right bundle branch. And then we have the left bundle branches, but that's actually split into a loop. And they meet here. And so collectively, this is the left bundle branch. And this is the left anterior fascicle and the left posterior fascicle. All right, so I'm going to hold up my hand. So this is what it looks like. So if this is my left ventricle, the left anterior fascicle is here, the left posterior fascicle is underneath. Now, I'll bring it up later when I talk about bundle branch blocks, but this is relevant. So if you're following along, go ahead and draw that loop, maybe a little bit neater than me. All right, so if we're going to do a QRS, let's draw this kind of big. Here's the P wave. Here's the PR. Here's the QRS. And here's the ST segment. And here's the T wave. All right. Now, when the sinoatrial node fires, it's here. Okay, so this is the sinoatrial node. When it goes across to the ventricles, that's this entire portion. Sorry, atrium. So this is when the atrium contract. Now over here, this pause is where the AV node holds onto the electrical signal. Down here, the QRS spike, it's very fast. That's why the time course is so narrow. And this whole thing is the Purkinje fibers. So this includes the right bundle branch and the left bundle branch. Following me so far? Okay.
Yeah.
This entire portion is the ventricle. Actually, it's more like here. Give me a sec. This is the ventricle firing. And the T wave is the relaxation of the whole system. Now, if you were to guess, which section do you think uses ATP, the energy currency? Which section uses ATP the most?
Probably the QRS or the Purkinje fibers fire.
Winston?
Yeah. That's what I would guess.
So funny enough, um, here is where you need energy.
Relaxation?
Yeah.
Hmm.
All
Really?
right. The way I remember this is, do you know why people go into rigor mortis?
No.
They run out of ATP.
Oh,
So you
Mm.
you need fresh ATP for the muscle to relax.
interesting.
You break ATP to release energy for the power stroke, for the muscles to contract.
Oh, so they're in a
That's interesting.
contracted state.
Yeah. So when someone's in rigor mortis, they're stiff because they don't have ATP to relax.
That's
Hmm.
interesting. Never knew that.
For heart attacks, if you have a blockage, You don't have ATP in that area, right? So do you see why it's do you see why it's this portion that'll start looking funny?
Yeah,
Okay. So
that's
so if you
wow.
have a heart attack, oh, come on, computer.
Funny how we've been doing this for years and we never knew
Okay, so
that.
this is why things change here for STEMIs, and this is why
Gotcha.
T waves change first for STEMIs.
Yeah.
Because you don't have ATP, you can't relax properly, and then eventually the ST portion gets all jacked up. And when you look at a an ultrasound, the region that has a STEMI is the part that doesn't move.
Oh,
So usually the ventricle will contract. And
right.
let's say you have a STEMI up here, it'll contract like this.
Oh,
Yeah.
Mm.
Okay. And this is why
recorded.
when
I see
you,
you're recording this, right? Sorry to
yeah,
interrupt.
yeah, yeah,
All
yeah.
right, great.
Okay, so when you buy steaks, for instance, at the supermarket, the cow's been dead for a week. If they sell it immediately, it'll actually fibrillate when you cut it, which is
Oh,
Oh,
creepy. I know, right? And it'll contract if you salt it.
huh.
Uh-huh. So they have to wait a couple days for that effect to completely disappear, and that's how the steak is nice and loose.
okay.
Okay, but that helps you remember, I hope, right? Okay, so
Yeah.
this is why STEMIs are here. All right, so I'm going to just kind of remove this to give myself some more space. Okay, so in terms of labeling, this is the P, this is the PR, and this is the QRS. This is the ST, this is the T wave. Now, if you have an EKG in front of you, or here, how about this? Like, go on Google and pull up like just a normal EKG.
Okay.
Um, Now, do you see like the pink grid on the EKG?
Yeah.
Okay. Let me know if you found one, Ian.
Yeah, I got one.
Okay. Now, you know how there's heavier lines, right? Thicker lines.
Yeah. The
So
little boxes.
Good.
10
So we're gonna talk some.
seconds or something.
We're gonna talk about boxes. You ready?
Sick timing, right?
All right. If you're looking at my screen, this is a large box. This is 0.2 seconds. And there's 5 subdivisions, right? 5 little boxes horizontally and vertically make up a large box. So if you're going to divide that by 4, how much is this? Sorry, if you're going to divide that by 5, how much time is the little box? What's 0.2 divided by 5?
Uh, 4.
Yeah. So 0.04. Okay. Now, so 1 second is how many large boxes?
5 of them.
That's right, 5 large boxes. Now, if we're going to multiply this by 60, so it's 1 minute, how many large boxes will it be?
12?
No, what's 5 times 60?
Oh, 5.
5 times 300.
300.
There we go, 300 large boxes. Now, did you guys ever learn how to estimate rate by counting large boxes?
Yeah, and like the
Okay.
classes and stuff, but
So let's say I'm going to use this as a shorthand. Whoops. I'm going to use, all right. I'm going to use this as a shorthand for a QRS. Okay. And let's say I have a QRS at the start of a large block. All right. And let's say at the exactly when the large box ends, I have another QRS. And I'm going to use this as shorthand for large box. Okay. So this is 1, 2, 3, 4, 5 large boxes. So this is 1 second. And I have a QRS at every single large
That's
block.
pretty fast.
Exactly, that's pretty fast. But over the course of a minute, how many beats are there? How many heartbeats?
So that's 6 a second times, what is it,
60.
60?
So that's five.
Yeah, so
We're counting this as zero. So this is one,
Oh,
two,
okay.
3, 4, 5.
5 a second.
Times
So
60.
300.
300.
Yep. So if you have a
Yeah.
QRS at every single beat, this is
Hmm.
300 BPM.
Yeah.
All right. Now let's say you have a QRS at every other box.
Be 150 then, right? Just
Hmm.
There we go, 150. How about every third?
70. No, it wouldn't
75?
be.
Almost. What's
No.
300 divided? So this is 300 divided by 2. What's 300
Divided
divided
by
by
4.
3?
Oh,
Remember, this is 1, 2, 3 large blocks. 1,
100.
2, 3. Yep, 100.
Yeah.
All right. Now what's 1, 2, 3, 4? How much would that be? What's 300 divided by 4? You guys said it earlier.
75.
There we go. And then 1, 2, 3, 4, 5. All right, it's 300 divided by 5.
60.
All right. So I'm gonna write here's so 2 blocks, 3 blocks, 4 blocks, 5 blocks. What's 6 blocks?
What do you mean?
If it's
It would be 6 divided by 300 at that
1,
point,
2,
right?
3, 4, 5, 6. Yeah.
Oh, I see. 50.
Yep, 50. What's 4 blocks? Sorry. What's 7 blocks? I'm running out of space here.
42?
Yeah,
Let's say 43.
42 point something. Yeah. Okay.
Yeah.
All right.
Okay.
So if you guys hand me EKGs, right? If you notice me counting blocks, for instance, this is exactly what I'm doing. All right.
You're
So
matching the rate.
Yep, I'm matching the rate. So what I do is I start at a QRS that on the rhythm strip at like lead 2 or V5. You know how there's like a rhythm strip at the bottom? I look for a QRS spike that lines up with a large box,
Gotcha.
and then I start counting down.
Okay.
Okay. So we're going to practice this together, actually. So I'm going to stop sharing for now. Wait, how do I? Oh, there we go. Stop share. Okay. All right. Do you see me again?
Yeah.
Okay. All right. So go down to the rhythm portion.
Um,
All right. Do you find one that lines up kind of with a box?
oof.
It's
Um,
fuzzy for me.
Oh,
yeah, I got my face close to it.
Um, hold on. How do I make you big?
actually, here, let me see if I can do it online then.
Is there any way to zoom in? Well, even then,
Man,
still, it's a
not quite.
pixelation issue,
Yeah.
and I'm ripping out here.
Your Starlink isn't
Yeah, well, we're killing time. I deleted it. I'm like 300 megabits per second, and my latency is only 20.
Yeah, here we go. Normal EKG. Open image in new tab. Okay, let's do this again. I'm going to share screen 1. Begin. All right, do you see this?
Oh, yep.
All right. So if we're going to go here, all right?
right.
All right, so this is 1, 2, 3 boxes. So what's 300 divided by 3?
100.
Yeah, so this is
Yeah,
about
100.
100 beats per minute. Okay?
Interesting.
Yeah. Um, let's see. Actually, give me a
This
moment. I'm going to see if I can pull up an EKG of my own. We can do another one. Uh, there we go. And go. All right, do you see this one?
In black. Oh, there we go. Okay.
Yeah.
Okay. All right, so we're gonna find what's a close one here. All right, so here's something that hopefully you'll notice now, or if not, maybe I'll point out to you and you'll see. Every feature that you see on the QRS, like I know for a fact that on this lead, the T wave ends right here.
Okay.
Because the T wave ends here, down here. Okay. Everything that you see, every feature that you see lines up vertically in time.
Okay.
Okay. So if you can't find something, if you can't find like a P wave, if you can't find like where Q wave ends or ST segment begins or ends, look vertically up and down to find that feature on one of the other tracings. And that's where you know where it'll be. So for this one, do you see how this, are you able to see that it lines up with this large line?
Yeah.
This heavier line? That means every QRS spike should roughly also line up here. Okay. Anyway, okay, so that's an aside. Now, how many large blocks is this? One large block, two large block, and not quite to the third one. So,
Okay.
if it's two large blocks, what's the heartbeat? What's 350? Sorry, what's
150.
300? Yeah, 150. Okay. How about 300 divided by 3? It's
100.
100. So this QRS is somewhere between 150 and 100, and probably closer to 100. What are you going to guesstimate it to be?
120, 125.
Okay, sure.
117 because it's on there.
Yeah, Rynston, you butthead.
I was taking it serious, Rynston.
Yeah, okay. But you see how this is close? This is closer to the 100, right?
Yeah,
Instead
yeah.
of to 150. Okay. All right. Now, before we continue to the next portion, then, draw somewhere on your sheet, kind of a block of, let's see, 4 by 3. So 1, 2, 3, 4, 1, 2, 3. Okay. And label it lead 1, 2, 3, AVR, AVL, AVF, V1.
Wait, hold on.
2,
You
3,
actually
4,
want
5,
us
6.
to like draw this out?
Yeah, draw this out somewhere. Just like a 4 by 3 grid, and then just label it. Because we're going to fill this in together.
Set a 4x3 grid.
Yep, 4 by 3 grid.
All right, and then what are we doing?
4 by 3 grid.
Yep, so 4 across and then 3 tall. And then inside the boxes, label them lead 1, 2, and 3, kind of like the EKGs.
Okay.
Okay, all right. So kind of set that aside for a little bit. I realized I skipped something. Sorry. That's why I'm doing this trial run, right? We need to talk a little bit about numbers. We do have to memorize a few numbers, okay? So let me just move this up here. All right, so we're going to use, we're going to use this actually. All right, so right now what we're going to focus on is this one heartbeat tracing, okay, the P, Q, R, S, T, all right? So P, Q, R, S, T, these are important. Okay, so you do have to memorize some numbers if you want to start interpreting EKGs, all right? So the PR is technically not quite correct the way I drew it, but it's just kind of for simplicity. But I'm going to change it a little bit. The PR is here. Okay, this is known as the PR segment. And then this is the ST segment, or there's another interval. I kind of
Yeah, I think it's interval. It's like PRI.
Yeah. So the PR, what we're looking for on the EKG, if we're looking for heart blocks, for instance, the PR, oh my gosh, the PR, the PR equals one large block, okay, which is 0.20 seconds. So if you see like a PR prolongation on the EKG, that means it's longer than zero point 0.2 seconds. And you can see it to see if the P to the R is bigger than one large block. The QRS should be 3 little blocks. Okay, and if a little block is 0.04 seconds here, QRS is what's 0.04 times 3? 0.12.
0.12.
Yep. And then let's see, and then the QT, this is the QT. The QT should be, yeah, man, this is rate dependent.
Okay. Does the QT start at the end of the QRS, or is it
The
like
QRS
just so
is
you don't?
usually so narrow, it doesn't matter.
Okay.
And I let the machine handle this one.
Okay.
Mostly because there's a correction. There's a correction formula. Okay. There's kind of a black box correction formula that I never remember. I let the machine handle it. All right. Because think about it. If you're going to have a heartbeat, let's say someone's racing down the parking lot, right? The heartbeat's narrow in time. Where are you going to get more time? Are you going to shorten the QRS any? Are you going to shorten the P wave any? Maybe some of the PR. But the majority of when you're going to save time to get more heartbeats per minute is by crunching down on the QT. Okay, think about it, right? When you have someone with tachycardia, SVT, their QRSs are just as long as normal. But the gap in between, the rest period, is when the heart starts cheating. It'll start narrowing the QT. So the faster the heart rate, the shorter the QT. The slower the heart rate, the longer the QT. And so this correction has a rate component to it. You can either do the formula, or you can use a lookup table, or you can just do what I did and let the machine handle it. And so this is with the correction. This is the QTC, it's QT correction. What you want this to be is less than 500 milliseconds. Whoops, 500 milliseconds. This is important for toxicity because medications that prolong the QT,
Zofran or antiemetics, right?
yeah, Zofran, antipsychotics. Zofran's probably the worst of the antiemetics. Methadone, especially. If people are on methadone, if you start giving them antipsychotics, you can put them into torsades. Okay, so this needs to be less than 500. All right. Generally, as long as it's less than 500, I give whatever I want. I don't care. If it's over 500, I start being cautious. If it's over 600 and this is a new diagnosis, they get admitted because they need to get this taken care of, or they need a pacemaker, or sorry, an
Okay.
implantable defibrillator. But usually these are metabolic derangements, so they get admitted for this to be corrected, like
I
give
was,
them more
so
magnesium or what have you.
I was gonna say, is that why we give magnesium if they're prolonged QTs to help it relax more then?
Yeah,
That makes
yeah.
sense.
All right. The other thing is if this is the QRS, okay, if this is my shorthand QRS spike, and this is the T wave, the QT, if the machine, for whatever reason, if it's not giving you a QTC, the T wave has to be shorter than the midpoint from spike to spike. Okay, as long as the T wave ends before the midpoint, this is going to be less than 400 milliseconds for the QT. if the T wave like ends all the way here, all right, and this is, this is the point I'm looking at, and it's past the halfway point from spike to spike, this is long QT. I don't care what the number is.
Okay.
Long QT syndrome. All right. So if the machine can't give you a measurement, this is your fallback. See where the T wave ends. Does it meet at the halfway point, or does it start trying to punch the next QRS? All right. That's a lot. Any questions so far?
No.
Okay. If PR is prolonged, this is a first degree block. Second degree blocks are not listed here, okay? But if the PR is too long, long PR is a first degree block, okay? If it's longer than the 0.20 seconds. Okay. All right. We could go into heart blocks a little bit next. And then after that, we'll start going through the zones of the heart so you can learn about STEMIs and locations. All right. Okay, so this is your break for questions, and then we'll go into arrhythmias. Any questions so far? Looking at the mumbo jumbo on this page.
Nope.
None. It's just
None?
it feels like a lot to me.
Yeah.
Like
Yeah. No, so here's the thing. If you
I
can
was not
start,
prepared.
that's okay. If you can use this image, if you can draw the anatomic heart, get to SA, AV, and then these bundle branches, you can trace yourself this QRS tracing. Okay. And then from here, like the PR, the QRS, the QT, and then if you can just remember that the back half from the QRS to the end of the T wave is like the ventricle contraction and relaxation, you can figure out a lot of physiology. And then if you can memorize some numbers, okay, if you look in a EKG book, it'll give you a ton of numbers, but if you can remember like the large, I don't care if things are too short in an emergency department, right? If the PR is too short, who cares? If the QRS is too short, who cares? If the QT is too short, that means I can give them more Haldol, right? I love it. All right. But if you can remember the upper extremes of normal, 0.20 for PR, 0.12, or for me, I remember them as blocks, right? One large block is a PR. 3 little blocks is the QRS. Anything longer than that, they're abnormal. And then here, as long as the QTC is less than 500, hey, we got room to play, right? And so if you can get this diagram, draw your own EKG heartbeat once, and remember these numbers, you can start generating a lot of stuff. And then if you just remember the kind of like how there's 300 large boxes in a full minute, great. Now you can start tracing, like now you can start counting heartbeats and what the heart rate is without the machine helping you. So yeah. So remember some diagrams, remember just a few numbers, and you can generate a whole ton of information in your mind. So while Ian is furiously scribbling, I'm going to circle some things that's worth remember. Oh, shoot. All right. So be able to draw this, be able to make this. All right. Remember large blocks and little blocks. And then from here, you can figure out that 1 minute is 300 large boxes. And then from here, if you can remember some key numbers, you can start knowing like abnormals. Okay. And the rest is just chicken scratch while I'm trying to explain stuff. So here we are. All right, cool. I'm going to move the page. Is that okay with you, Ian?
Yep.
All right, great. All right. All right, so here we are. One more time. P, Q, R, QRS T. Okay. Now I'm going to simplify it as this. This is P wave. This is a QRS. Okay. So P QRS. Okay. So first degree heart block. That's when the PR is too long. Okay. Do you see how this is starting to migrate away? All right. So this is a long PR. Oh my gosh. I'm not awake. So this is a long PR, which is greater than 0.20 seconds. Second degree heart block. You guys remember the terms like Mobitz type 1, Mobitz type 2? All right. Ian, does that ring a bell? Sound familiar?
Yes.
All right. So a Mobitz type 1 is interesting. You start out with a normal or even a narrow PR, and then at the next heartbeat, it gets farther and farther away. And then it's gone. And then it starts over again.
Oh, the longer drop.
Drop,
Yep.
yeah. Winky Bach, right?
Yeah.
Yeah.
Okay, so this is a Mobitz type 1. Or the, oh my gosh, Winky Bach. Whatever. Okay, great. All right. Sorry, penmanship. So this is second degree Mobitz type 1. Mobitz type 2 is interesting. Mobitz type 2, the P and the QRS should be all the same until it's not. Okay, the PR does not change. This is Mobitz type 2. All right. Okay, you can see the difference between Mobitz type 1 and type 2, right?
Mm-hmm.
Okay, third degree. I'm going to do my best to try and keep the P the same as, the stuff above.
Yeah.
Oh boy, oh my gosh, it's starting to have problems. Okay. All right, sorry, my drawing tablet froze out for a little bit. Okay. All right, so third degree blocks, you have their P waves, and then you have the QRSs, and they look like this. They look like left bundle branch blocks. They don't match, which is terrifying, right? This is a complete heart block. All right. So patients like this, they get admitted, if it's a small hospital, to the ICU. Oh yeah, no, this just gets admitted to the ICU. And then they get a pacemaker the next day. All right, so that means there's a complete disconnect between the upper half of the heart and the lower half of the heart. Okay, so a complete heart block is a signal block right across the middle. And the ventricle and the ventricle and the atriums, they just don't match anymore. That's why the P waves have their own tempo, the QRSs have their own tempo. Now, the nice thing about the heart, as God made them, is that there's backup pacemakers from top to bottom. The top part of the heart, if you surgically scar out or remove the SA node, the AV node will actually kick in. You get a junctional rhythm. So if normal is about 70 or so, the junctional rhythm will kick in somewhere in the 50s. If you completely just disconnect everything from top to bottom, AV node's gone, SA node's gone, all you have left is just the ventricles trying to keep their own beat, 40s to 30s. So this is why people with complete heart blocks have a slow heart rate between 40 to 30. All right. On this, I'm also going to draw a line. This is okay. Down here, pacemaker.
For type 2 as well, you're saying?
Yeah, for
Okay.
type 2. Because type 2s can become this.
Oh, okay.
Yeah. It almost doesn't make sense.
So
Why
it's a
this
kind of a
is
progression then?
not quite.
No, not quite. Okay.
Not quite. The Mobitz type 2 is something that's just completely injured and wrong with the AV node. Mobitz type 1, the AV node is just misbehaving, but people can walk around with Mobitz type 1 for decades.
Okay.
Type 2 turns into kind of this time bomb that you don't know what the timing setting is. Because this
Yeah.
can flip over to complete heart block. I've seen it happen once in my shift. Okay. And the way I rationale this is like the AV node is misbehaving. There's a lag, there's a lag, there's a lag, and it just occasionally drops a beat, but it goes right back. Here, things conduct, and it gets swallowed up. Something just disappears. Okay. And just like China making people disappear, this is dangerous. Okay. Does this help you remember it? I know. I'm doing great. All right.
Professional.
I know, very professional, right? And I get to make that joke because I'm Taiwanese. All right, good. Looking at this, any questions? Any questions before
No.
we move on?
Nope.
Okay. So if you're handed like some Wonko EKG, for instance, what you want to do is just you want to count. Sorry, you want to look for P waves. You want to make sure that after every P wave is a QRS. After every P wave is a QRS. And if there isn't, then you can start looking at these patterns. Oh, okay. Is this just there a large gap between the P and the QRS? Does the gap get wider, and is that why a beat disappears and it looks kind of weird? Or do the P and QRS look normal until it's not? Oh, okay, that's a type 2 then. Or if the P waves are all there and then the QRSs start just complete disconjugate, completely doesn't match. You get a third degree block. Okay. So look for P, make sure there's a QRS following, and make sure it's nice and close and doesn't go anywhere else. All right. Let's see. And then you guys know atrial fibrillation, right?
Yeah.
Okay. That's when there's no P wave. It's just this wiggly line, and you get QRSs kind of, every which way.
Sporadically.
Yeah, sporadically. That's the hallmark of atrial fibrillation. This is irregular. Oh my gosh. Irregularly irregular. These are just irregular. And then the third degree is just block. Okay. So irregularly irregular seems kind of like a redundant phrase, but it's irregular and unpredictably irregular, which is the hallmark of atrial fibrillation. So then that's why it's irregularly irregular. Okay. PR, Mobitz type 1 and type 2, they're predictable, right? Because you can see the pattern of the QRS, the P and QRS getting wider and wider and wider, and then this one is just kind of disappears. You can predict, or at least you can see the regularity. So this is just simply irregular. You can usually there's some like ratios, like a 3-to-1 or a 4-to-1 or 2-to-1 of like regular heartbeats and then your dropped beat. Okay, so for a lot of these Mobitz types, you can just kind of march them out. And then I guess third degree is irregularly irregular too, but at this point it doesn't matter. It's just nothing. Nothing is connecting. So this is just block. Okay. All right. So if you see regularly irregular, it's not because someone had a seizure and just decided to write this word twice. This is AFib, and it's unpredictable. All right. Cool. Pause for questions as I clear the page.
No questions.
Any questions? All right, good. All right. Brains feel full yet? All right, so we're going to draw our anatomically correct man. He's going to have bowling pin legs and bowling pin arms. All right. And if this guy's seeing me in the emergency department, he usually looks like this. Here we go, twiggy neck. All right. Okay, so everyone does it maybe a little bit differently. When you two are putting on EKG leads, the limb leads, where do they go?
Arms, legs,
Arms and
Yeah,
legs.
it's,
or
Okay.
like
yeah.
lower
Yeah.
belly for the
Yeah. Okay. So
core.
usually
It
you
depends on
have
how
it
much they're moving. Yeah.
exactly, right? So usually you have maybe the arms at the shoulders
Yeah.
and then leads at the legs. All right. I'm gonna draw the leg leads like this
Okay.
because the machine only cares about one of them. The other one is a ground.
Ground.
Okay. So the limb leads are in the shape of a triangle. Okay. All right. Give me just a sec here. All right. Good. So we're only looking at the limb leads now. Okay. And so as far as the machine is concerned, it actually maps it out into an equilateral triangle. Okay, so across the arms, this is actually lead 1.
Oh,
From right arm down to the leg, this is lead 2. To left arm down to the leg, this is lead 3. All right, and then you guys, the AVL, AVR, AVF, right?
yeah.
Mm.
Okay. So while you're doing this, while you're copying that, I'm going to draw my own grid. Give me a sec. Okay. All right, so this is, oh, almost. Oops. All right, this is similar to the grid that you guys have, right? All right, so this is, oh my gosh. So this is lead 1, this is lead 2, and this is lead 3. This is how it's laid out on the QRS tracing. AVR, AVL, AVF. And this is V1, V2, V3, V4, V5, V6. All right, so limb leads. Here's lead 1, lead 2, lead 3. All right, so what I just drew here in this triangle corresponds to this first column. Now, these are actual measured EKGs, right? These are actual measured electrical energy. The AVR, AVL, AVF, these are mathematical trickery to generate 3 more directions, 3 more vectors. Okay, so these are virtual leads.
Oh.
Yeah. Oops. Oh my gosh. So AVL, AVR, AVF. So these are virtual leads. Pretty neat, right? All right, so I'm gonna move something here. Here you are. All right, we'll come back to that circle in a little bit. All right, switch pad. Now, just looking at this triforce of power, whatever, right? Can you guys guess which one are the inferior leads? These are the leads that point generally down. Okay, so that would be 2, 3, AVF. I don't know if you've heard attending say, oh, it's an inferior lead, look at Q3 AVF or whatever. These are inferior leads. And on this, they correspond to here. This is a zone of the heart. All right. So on the heart, if you have like a distal LAD or a distal like right main that's blocked, you start the bottom tip of the heart starts getting affected. Usually this will be like a right coronary artery. If the right coronary artery, which is if the heart sits like this in my chest, the right coronary artery is responsible for the inferior portion. Okay, so if you have a heart attack towards the bottom, you start seeing ST and T wave abnormalities down here in this region. Okay, so these are inferior leads. All right, so I'm going to just write this here. Inferior equals 2, equals 2, 3, and AVF. All right, knowing that, Rynston, what are the left lateral leads?
Let's see. AVL 1
And
and 3.
no, just AVL
Oh,
and 1. AVL and
okay.
1. Okay, because these are the arrows pointing to the
Oh,
left, right?
Oh, I
Do you
gotcha.
see how
Okay.
the inferiors, they're pointing towards the bottom?
Yeah.
Okay. So this is the left lateral. Okay, so left lateral equals 1 and AVL. Okay, 1 AVL, and there's 2 more. We'll get to in a
Is
little
that
bit.
what the L stands for? In AVL?
Yeah, AV left
Oh,
and the AV right and every foot.
gotcha. Okay.
yeah, that's what I thought earlier was the
Yeah.
foot. I didn't want to say it though. I was like, that's dumb.
Okay. All right. So we're going to focus on vectors a little bit. Okay. So if we bring all of these arrows, think of these arrows as detachable, these vectors. Okay, think of like AVR, AVL, and lead 1, 2, and 3. Think of these as detachable. Now, if you want to, you can move AVR, AVL, and AVF very simply over here. Oh, whoops. Okay, you can move them to the center point. So if you take all of these vectors and plot them to start at the center of a circle, they are all right here. All right. Now, lead 1, you can take this arrow, okay, and drag it over here. Lead 1's nice and simple as well, too. It goes straight to the left side. So this is lead 1. You can take lead 2 and drag it over here. Lead 2. And here's lead 3. Okay, you don't change the angle, you just slide them along. Okay. So if you, in your mind's eye, if you take this horizontal left pointing arrow and move it over here, that's lead 1. Take lead 2, transplant it over here. You're just sliding these arrows along. And if you make all of your tails start from center, this is what it looks like. And just like a heart at this point, what's at the bottom of the circle? The inferior leads, 2, 3, AVF. What's at the left lateral? Oh, lead 1 and AVL. Okay, do you see how this is all kind of grouped together now?
Mm-hmm.
All right, good. Now we get to the precordial leads. Okay. So this looks at the person on a plane. Now let's say we just cut this guy in half right here. Blech. All right. That's essentially what the precordial leads are. It's the heart's electrical tracings on a horizontal plane through the heart. So with the precordial leads that you guys put on a patient when you're doing EKG tracings, V1, V2, 3, 4, 5, 6, it's if you take this circle and you tilt it 90 degrees, okay, and if you can imagine this sitting on a plane, it would look like this. V1, V2, V3, V4, V5, and V6, which is perfectly horizontal.
Gotcha.
Okay, so this is V1, 2, 3, 4, 5, V6. Okay, so let's say we take this, and we, oh gosh. Do you see how if we line up V6 and lead 1 together, you end up with a sphere?
Mm. Ah.
I know, clever, right? I didn't make this up, someone else did. All right. So when you're looking at an EKG tracing, you're actually looking at a spherical representation of the electrical activities of the heart. It's pretty neat, huh?
Yeah.
All right, we're going to get to a third color now. Ready? So, knowing this, what are the anterior leads?
Mm.
What are
Would
the
V
be
leads at the front of the patient?
V1, 2, 3, 4, 5. I mean, I guess
talking about the arms and the feet.
Oh, just the anterior part of the heart.
1, 2, 3.
Yeah, so anterior equals V1 through 4. All right, knowing the complete picture, what are the missing ones in the left lateral leads?
uh 5 and 6, you're saying? Or-
Yep, that's right, V5, V6. Hi.
Hi, Emily.
Hello. Rynston says hi, Emily. Oh. Ian, you've never met Emily before, right? No. Okay.
No,
Yeah, you skedaddled before I could have you over.
it's okay. I saw
Okay.
her running through there.
Yep. Okay. So, looking at the EKG, the 12 lead EKG, we already know the inferior leads, 2, 3 AVF. Okay. The left lateral leads now also include these guys. Whoops, shoot. Okay. And the anterior leads include these guys. Now, why is this important? If you want a true STEMI, right, if you have some blood vessel of the heart blocked, you're not going to get abnormalities in one lead only. You're going to get abnormalities in the zone. So what we're looking for is ST elevations. Now remember how I said, if the heart's a steak, if you run out of ATP, it starts looking weird here. All right. So this is the part that becomes problematic. The T wave looks weird and the ST looks weird. Do you see how this is starting to rise up instead of
Yeah.
at the normal? Okay. When you're looking for these things, what you will see is that um, you will start seeing this abnormality in multiple regions. Okay, you'll see a QRS elevation maybe in 3, and then you might see it slightly less dramatically in like AVF, for instance. Okay, that tells me that, okay, that whole portion of the heart is in trouble. Now, have you heard the docs mention reciprocal changes?
Mm-mm.
No.
Call.
Okay, so reciprocal changes, let me see if I can get this to work. Ba, 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 ba. All right, sketchpad 2. And then edit and do transform image. Ah, horizontal. Oh my gosh. I don't know if I can do this. Oh, you know what? Here, I'll do it this way. That's a teeny tiny one. It's adorable. Nope. I'm using a new art program that I'm not familiar with. There you go. Okay. Why did I flip this? If you have an ST elevation in one part of the heart, you should see the echo of it on the opposite end. Does that make sense?
Mhm.
If you think of each of these vectors as a camera, when you see an electrical signal go towards that camera, you'll see it pop up. If it goes away, it pops down. So if you have an ST elevation in one part, somewhere else it's going to look like the electrical signal is going away, and you end up with down. Stop me if you have questions. Okay, so if you're looking for an ST elevation in one part, you need to find an ST depression at some other zone, preferably the opposite, but the heart's never that precise. All right, so if you see ST elevations in, like, for instance, 2-3, you should see ST depressions in, like, some anterior lead or some left lateral lead. Okay, if you have all of these features, if you have STEMI and more than one, whoops, if you have a STEMI and more than one EKG lead in the same zone, okay, so STEMI's more. All right, come on, computer. You guys are still here, right?
Yep.
Mm.
I'm always neurotic. That's crashed. Okay, if STEMIs are in more than one tracing. Oh, geez. Okay, and in the same zone. Okay, that's a real ST elevation. And if you really want to sell it to the cardiologist that this is a real deal STEMI, you're going to look for the echo somewhere else. Okay. Now, for the left lateral leads, it's especially important. If you see a STEMI in AVL and V6, that's the same zone, even though on the page they're not contiguous. All right, very rare, but sometimes this happens. Okay. So if something is positive in, like, lead 1 and V5, even though they're not next to each other on the page, they're next to each other on the person. All right?
Mm.
Okay, so that part throws people off. V5, V6, and lead 1 and AVL, they're left lateral. You have to remember that these opposite corners actually are next to each other on the person. Okay. Anterior leads, that's easy. They're all these four, they're just sitting right next to each other. Inferior leads, same thing. They're right next to each other down here. All right, if you guys don't mind closing your eyes for a moment, we're going to look at some EKGs. All right, open. Do you see this one?
Yep.
Okay, all right. So, walk me through this, you guys. Talk me through.
Uh, I feel like
Gosh.
um in V1, right there at the V1, am I looking at anything that's reciprocated in 1, 2, 3, and 4, or is that normal? Or are we
Um,
more worried about? I'm
Is
probably
it?
not seeing anything.
yeah, let's go by zone, okay? Let's look at the left lateral. What do you see going on with the ST segments?
It's a depression, right?
Yeah,
Is it the
yep. Do you see how
whatever you
there's a
call it?
depression here
Yeah,
and a depression here? All
yeah,
right,
the
okay,
echo.
so this is the echo. All right, let's look for the problem somewhere else. Let's look at the inferior leads. Oh, mama.
Yeah,
This looks awful, doesn't it?
yeah.
Yeah. All right. The precordial leads, they look weird.
Uh,
Okay, and these are starting to tombstone. Do you see how this is
yep.
starting to push up? Okay, so this is like inferior and septal-ish or whatever. All right. But the slam dunk diagnosis is we have gigantic ST elevations in the inferior leads and reciprocal changes at the left lateral. This one's easy for the cardiologist to sell to. Right? It's like, oh yeah, one just like five, oh geez, like 6 millimeter elevation in lead three. Yeah, please come in. They'll be like, all right, cool. You sold me. I'm on my way. A lot of times, if you describe it this way, they won't even bother wanting me to send them an EKG. They're like, yeah, I'm right over. We'll activate the team. Okay. All right. Close your eyes one more time.
What's a widowmaker then, Gordon? Like, what is that into?
I'll explain in the Widowmaker. Yeah.
Okay.
Okay. All right. Open your eyes.
All right. So I think I see the echo on the right, and then uh,
ABR.
yeah, AVR. Looks like there's an echo there,
Yeah.
and then I would say uh, ooh, is it the left lateral? Like
All right. Pretend I'm the
one.
cardiologist. Sell me on it.
Uh,
Come earn your paycheck.
Yeah, you two earn your bloody paychecks already.
I guess. Well, I guess I'm working for
Hey,
free this week.
yeah. Hey, I'm
One
not in the ED
looks
anymore.
right. One looks funky, but I don't know what I'm looking at. Two, I feel like looks normal.
Yep.
Yes.
Three is inverted.
Yeah. It's
Yeah.
depressed, right? 3?
Yeah,
Yeah.
So
which
that's
what's
unfair.
tied to one, three, and AVF are tied together.
All
So are those reciprocal changes in two and three then?
right. So, yes, these are reciprocal changes in 2 and 3. Oh, no, no,
Mm-hmm.
no, no.
Wait, is
3 and AVF.
AVR?
3 and
Oh,
AVF.
so
AVF. Yes, I'm sorry,
AVR
AVF.
is not.
We'll get to AVR in a little
AVRs.
bit, actually.
Okay.
That's on its own.
Yeah.
Um, and then V1, I don't know what I'm looking at in V1.
Well, let's look at it. There's a P, there's a
AVL
QROS.
looks funky
But look
too.
at, do you see the ST segment? Is this higher
Yeah,
or
Yeah.
lower than the baseline?
Or
lower.
Yeah, so this is a depression. This is also a
okay.
depression if
Okay.
you start looking for it. Do you see how this is lower?
Yeah.
This
Mm-hmm.
is lower as well too. So there's a lot of depressions here. All right, so you guys are finding all the depressions. Can you find some elevations?
Yeah.
For sure
Three,
in
four,
one,
five,
Okay, yeah, that's right.
six.
for sure
Look
in
at how high it's hiked up here. It's
mm-hmm.
like 1, 2, 3. It's like 3 millimeters up. Yikes. Any other elevations? Remember, we're looking for contiguous now, right?
Yeah.
What are the other leads associated with 1?
uh AVL. So yeah, AVL
Yeah,
matches.
good. What
And
else
then
is left lateral?
V5, V6.
Do you see how this T wave is high?
Yeah.
Mm-hmm.
Yeah. And this is about a millimeter up. Okay, so
Okay,
this is
compared to the
slightly
So with it
elevated.
QRS.
being
Okay.
V4, V4 is kind of elevated too, no? Or
Yeah, so
okay.
remember this is like all an arc around the patient's left side, right?
Okay. So it's just that
So
region.
yeah, that region. No one's hearts are like perfectly anatomically aligned.
Okay.
Okay. So this is a left lateral STEMI with a lot of reciprocal changes in the inferior and also anterior leads. This is a pissed off heart, right? Okay, close your eyes one more time. Okay.
All right.
Oh,
So anterior elevation, and
yeah.
then I think
So
recip
V1 is elevated. The what is it, PQR? The ST is elevated. Two. I don't know what I'm looking at. Two.
Well, let's look at it. Where's it? Is this the P wave? All right,
Yeah.
so this is the baseline now, right? I
QRS.
usually like to use the PR as the baseline.
Okay.
That's kind of
Okay.
like electrically boring. So it's just going to sit there in a flat line. Here's the QR. What the hell is this?
That's
That's the
a
T wave.
STEMI.
Yeah, this is like six little boxes up. This is huge.
Yeah.
All right.
Hmm.
Now that you see that, can you see this?
Yeah.
Yeah.
Yeah, it's also pretty big. This?
Hmm.
Yep.
Now,
Four.
this is an
Awesome. Yeah.
interesting thing. Do you see how tiny the QRS is in
Yeah.
relation to a T wave? So sometimes all of this can be normal, and this is what I see, a tiny QRS and a big T wave. This might be the first sign of a STEMI. Remember how we talked about relaxation being what's affected by no ATP,
Yeah.
Hmm.
right? Heart has trouble relaxing. The T wave starts getting changed first. In fact, the T wave gets gigantic. So if you see a QRS that can fit inside a T wave, this is an early STEMI equivalent.
Okay.
Okay, so if you look at the QRS spike and ever wonder to yourself, gee, that's really small. It looks like the T wave can eat it. That's a STEMI. I don't know if you think like that. That's the voice in my head.
So would you still page that as a STEMI then, or would it
If I
be
see
more
this,
so
it depends on the clinical
stereotrips?
picture, right? If the
Okay.
patient is like Ian right now with the baseball cap, just kind of nodding to whatever doc is saying, it's like, yeah, yeah, sure, doc. I don't know why you got an EKG. My left foot hurts. I
Yeah.
sprained it. Not a STEMI, okay? You might want to get
Okay.
serial EKGs to make sure that doesn't keep changing.
Right.
Maybe he twisted his left ankle because he had a syncope from his heart attack.
Yeah.
Yep, but he showed up because his ankle hurt more than his heart. But if on serial EKGs this starts changing to this shape, awesome. Call the cardiologist, sold.
Okay.
Okay. If they have a couple leads that look like this, let's say like V5 and V4, they both look just like this and everything else is normal. They're gray, they're ashen, they're diaphoretic, they're clutching their chest. Call a STEMI. I've
Right.
done this maybe 2 or 3 times in my career. It's like, wow, this is a hyperdynamic T wave with a teeny tiny QRS. Oh, the patient looks like dog poop. All right, call a cardiologist.
Okay.
Yeah, off they go. Okay. All right. That's kind of a aside. Yeah, where would what region? What regions are these guys in?
Anterior.
Anterior. Okay. Can you find some reciprocal changes? Now, usually
Ah.
when it's this big, when it's this obvious, like looking for reciprocal changes is kind of a just kind of an academic process only. This is such a nasty ST elevation. I
Yeah.
just called a cardiologist then. Yeah. But that being said, can you find any depressions?
Uh, is it kind of the inferior
Yeah, right
region?
here.
It's
Three.
very small.
Yeah,
Yeah.
it's very small. It's like 1 millimeter. But do you see how
What
this
about
T
eight?
wave is? Sorry, do you see how this ST is kind of like just curving down just a little bit?
Yeah.
Yeah. Um, these are also ST elevations.
Okay.
So this is an anterolateral STEMI, kind of a
Okay.
common finding actually. And anterolateral and inferolateral are also common. They're like these are two common combinations. Yeah. Okay. We'll be
With like AVR, would that be reciprocal changes too there?
yeah, yeah.
Okay.
This is such a nasty anterior one that the AVR is also starting to dip. Good eye, Rynston.
All right.
Nice catch. Now, I don't have an example on my computer. I have one in my car, but it's kind of hard to show on Zoom. I had one case where it was an ST elevation in AVR and ST depression everywhere else.
Weird.
That's a widowmaker.
Oh, okay.
Okay, I'll show you by going back to my drawing program. Whoops.
Probably find one online.
Yeah. Do you see how in this sphere, this AVR is like off on its own?
Yeah.
What's the reciprocal to the AVR?
Is it the
Everything?
Everything
SAAV?
else,
Okay.
baby. Yeah, that's
Oh,
right,
right.
Ian. Everything else. Okay, so I had this guy. He looked like crap. He was diaphoretic and pale, and he had an ST elevation of like 2 millimeters in AVR, and everything was depressed. And I called the cardiologist. I'm like, okay, you're not gonna believe me, but this guy has he has a STEMI and AVR. He's like, yeah, yeah, yeah. I'm like, hear me out. He has a depression everywhere. Every lead has a depression, and he looks awful. In fact, his oxygen is starting to drop. His blood pressure is starting to drop. Can you please come in? The cardiologist is like, all right, fine. So he rushes in, takes the patient to the cath lab, and we're all like, yeah, gee, I wonder what will happen to him. And Sutton remembers this story. He was with me for this one. He was still a tech. 10 minutes after he goes to the cath lab, we get this very panicked call from cardiology and cath lab. Come over, intubate the patient in cath. We're going to take him to surgery. He had a left anterior descending artery blockage, the LAD, okay, that feeds the left and the septum of the heart. This is a big blood vessel here, okay? It was blocked where it left the aorta,
Oh, wow.
okay? All right, so if you can imagine that whole blood vessel is screwed up. Whole blood vessel. And it was high enough. It was high enough at the very top of the heart where it was blocked at first that we saw the AVR STEMI. And the whole rest of the heart was the echo of that blockage. That was awful.
I just sent a link in the chat. This is kind of similar to what you're talking about.
Let's see, where's the chat? Let's
Okay,
see.
I see.
Yeah, this looks just like that.
Okay.
Yeah, this was terrifying.
So that's okay.
So long story short, so Ian, do you see the elevation here?
Let's see. Yes.
Yeah, all right. So if this is the baseline, boop,
hmm
boop, boop. Do you see how this is a depression here, depression
Yep.
here,
Yeah.
depression here? This is starting to depress as well too. Okay. Anyway, so long story short, that guy ended up going to the cath lab. I intubated him. He had some more vessels that were diseased. Ended up going up to the ICU and then died like 36 hours later.
I might have. I wonder if I was there. Like, I wasn't involved in the care of the patient, but I think I remember hearing about
Yeah, like I've
this.
brought this up before. I think I've showed you the EKG as well.
Gotcha.
Yeah. But this story kind of sticks with me because like I never intubated someone on a cath table before.
Right.
Yeah. All right, cool. You guys having fun? Want to do a few more before we call it quits?
Sure.
Sure.
All right, there's one more part of the lecture that I'll have to explain, which is like axis deviations. But that's irrelevant at your level. And for the most part, I don't know why they really teach it for us. I think just so that we know how to orient ourselves around the EKG. But like axis deviations are not as useful anymore because cardiac echoes exist, and that gives us information about like left ventricular hypertrophy, right ventricular hypertrophy, pulmonary physiology. So echoes gives us more accurate information than the EKGs. So getting an axis on the EKG is kind of like a dinosaur practice.
Mm.
Yeah, I find that it's not as clinically relevant, but if you guys get good at spotting EKGs, you fucking look like a rock star when you hand them to the attending. It's like, hey, I think there's a lateral lead STEMI, and they'll be like, yeah, you're right. Yeah.
Or like, wrong, idiot.
Oh my
Yeah.
gosh.
Stay in your lane,
Yeah.
nurse.
Oh my gosh.
Yeah.
No. All right, let's close your eyes one more time.
Okay.
Yeah. Uh, okay, all right.
All right. Let's see here. Anterior elevation.
Again, I'm saying that in
Oh,
V2 and V3.
yeah, yeah.
And then let's
And 2 and 3 look weird too.
2 looks
Wait,
weird, right?
uh, is this inferior elevation?
You guys
Because it's
convinced
like,
me.
oh
I
man.
see some,
Okay.
I see something in 2, don't I, Rinston?
Yeah, that's what I'm seeing that too. But
And then 2 and 3 for sure. That's definitely ST elevation in 3
yeah,
and
I'm trying the
reciprocal
reciprocal.
changes in the what's it, ABF? Yeah, so 2, 3. So for sure inferior, and
With
then
reciprocal changes in. Wait, no. You said where
V1.
do you see reciprocal
So
change?
in
Oh,
leads
uh,
2, 3 in AVF, I see a STEMI, or I shouldn't say that. I should say elevation.
you're right.
And then 1 and AVL look normal to me. AVR, maybe some type of reciprocal change, but I don't have the know how to articulate that.
Yeah, I
So
can't
I'm
tell
gonna
where
say
reciprocal changes are.
I'm
Yeah,
gonna
maybe AVR. Yeah.
I'm gonna say inferior.
Yeah, good. Very good. So these are, you guys correctly identified an inferior STEMI.
Mhm.
Now, there isn't much of a reciprocal change, actually.
Okay.
Maybe a little bit here. Do you see how the
Okay.
ST is kind of like lower than a baseline
Okay.
by just
Little
a
Yeah.
bit.
touch? It's very subtle. So for this guy, if he looks awful, and you have an EKG like this, and especially if your comparisons don't have these elevations, then yeah, just call the cardiologist.
Okay.
Okay, so this is a good one.
And that's when they tell you, no, it's not a STEMI. Just zero EKGs,
Oh my
heparin.
gosh.
Send them
No, no,
upstairs.
you send them this one. They'll say it's a STEMI. Like these are real and it's like in a zone too. In fact, you even see it a little bit in V6. Do you see the ST
Yeah.
elevation there?
Okay.
Yeah.
Yeah. All right. Good, good.
It's
All
not
You
very
right.
guys are
big, but
your eyes are starting to pick this out, right?
Yeah,
man,
Yeah.
I
very
wish I
much
was
so.
doing EKG still so I could play with it at work. Use it, actually use it.
I forgot your vascular
Yeah.
Yeah.
access. Living the dream.
I'm just gonna look at the rhythms on the
Well,
monitors.
how about this? When you look at the rhythm on the monitors, now that like if your eyes can start identifying these ST changes, if you see it on a cardiac monitor, um, what would you do if you saw it on a cardiac monitor?
Not my problem. I'm just kidding.
Tell the nurse they might want
Tell
to get
the
an
nurse. Yeah,
EKG.
Yeah,
yeah.
exactly. Get an
Take a
Yeah.
clinical
EKG. Like,
picture. Like,
Right,
hey,
right.
your
don't crap
patient's
about.
diaphoretic. I'm
It's
seeing
funny
something
because
funky
the
going on.
nurses don't even do EKGs at UW though. They have an EKG tech that goes around the whole hospital just doing EKGs. Isn't that
Well, you
funny?
talk to the charge nurse, right? This looks
Yeah, yeah,
awful.
yeah.
The patient looks
No,
awful.
for
Anyway,
sure.
the trap about cardiac monitors is you use that to look for rhythm problems. If it's like Mobis 1, Mobis 3, heart block, or
Yeah.
whatever, right? Because the cardiac monitors, they're not good for morphology.
Yeah, I remember you saying that.
Yeah. So if you see something wonky on a cardiac monitor,
It's
especially if
EKG.
the patient looks bad, get an EKG. Okay. And the EKG can either confirm or deny it, or and if it's there, you'll know where and which region. So you can start pushing the charge nurse, Rinston, to call the doc, to call the cardiologist.
Yeah.
Plus, when you get an EKG, like, I think same should apply upstairs. Like, the doc needs to see it within a few minutes.
Yeah, I have no idea how that works. Just do IVs now. I'm feeding tubes.
Oh my gosh, you poor soul. All right,
Yeah.
let's do another. Close your eyes.
All right, all right.
Okay, all right. Open.
Are you laughing? You fucking with us? Oh my God. Is
This is
this
the
even
one.
real? What
Yeah,
the
this.
hell is this? This guy is dead.
Yeah.
He's screwed up.
Oh, holy cow.
Is this?
Oh
I think I
my
cheated, but isn't this another Widowmaker?
God.
When I Googled Widowmaker, I feel like I saw this
Is it? No, because they're elevations and all all of them
everywhere. Yeah.
except for um the inferior, right? Yeah, those are
Oh, good. Hey, look,
depressions.
you guys got this within seconds. That's amazing.
Yeah. That's a dead man.
Yeah.
It's EKG of like, dead meat. Okay, all right. Let's start with the easy stuff.
Holy
Where's the
shit.
depressions?
Uh, I would say inferior.
Yeah, inferior. Okay, how can you tell?
What do you mean? How can I tell? It's just
It's
heavily depressed.
PQRS
Yeah,
is
Oh,
so
that the
this is the
ST
baseline, right?
segment is
yeah, yeah, yeah.
lower than
Way
Right.
your
lower,
P.
significantly
Okay,
lower.
good. Because I
Mhm.
want you guys to practice the baseline. The baseline is that PR right before
Mhm.
Yeah,
the QRS spike. Okay,
yeah.
Mhm.
so you can see that these are all depression, depression, depression. All right. Now, how did you guys know right off the bat that these were all ST elevations? Because you're right. I
Yeah.
want you to be
Mhm.
able to explain it.
I mean, there's if going off the baseline, like you said,
Yep.
they're significantly
Good. So
higher.
you can see the baseline here, right? Because here it's kind of hard to tell. It's like, gee, where's the
They look
baseline?
like
Is it here? Is it here?
tombstones.
Exactly.
Yeah.
Yeah, it looked like tombstones. So if you know
That's
that this is the QRS and this is the baseline, that's up. QRS baseline, that's up. And now you can
Yeah.
start seeing the morphology. Oh, okay, that's
mhm.
baseline. That's up. That's up. That's up. That's up. Okay.
Elevations and
So
depressions
anterior
and all
with
these
inferior reciprocity, is that what
Yeah,
how you
so
say it?
this is
Or
reciprocity.
anterolateral ST
reciprocity.
elevation with inferior reciprocal changes.
Okay.
Yeah.
Gordon, at ABF, what is that turning into at the end there though? It kind of
Oh,
looks
this is
weird.
probably a motion
Artifact.
artifact.
Okay.
You see how it's weird up here too and weird up
Yeah,
here too?
Hmm.
right.
Yeah, so if something looks weird or if you're not sure, look vertically.
Gotcha. Okay.
Yeah, good question. I hope I gave you a good answer.
No, that was
Yeah, no, no, no.
Yeah, good.
And you're making like you said, you need to look for your baseline and then your
Right.
changes from there. So it doesn't matter what it looks like. So it is really good information just to
Yeah, yeah,
sell it
yeah.
to you.
Looking for the
Yep.
baseline is really helpful.
Yeah, looking
Because
for
it's
the
like, oh,
baseline.
okay, this is a total mess.
Yeah.
Call the
Yeah.
doctor. But in reality, if you need to articulate that on the phone or whatever for whatever reason, look at your
Right.
baseline, then you
Yeah.
can sell it to them, like you
Yep.
said.
So
Instead of
this
saying,
is
yeah, it
this
just
is
looks
why I
fucked
was
up,
laughing,
man.
right?
Hmm.
I scrolled over to
Yeah.
this and I start chuckling. You guys, oh no, is this some trick question? No, no, it just looks so bad I start laughing. Can you imagine being the patient? Why is the
Yeah.
doctor laughing? Am I gonna die?
God, yeah, right.
Call the anesthesiologist. You got to fucking tube him
Jeez.
now.
Oh my gosh. Yeah, this looks like a dead man. All right. Close your eyes.
All right, all right. All right, give us a more difficult one.
Let's see. Oh boy. There we go.
We good?
Okay, yes, let's do it.
Oh, okay.
So,
All right, give me a moment. I'm going to make
Elevation.
this a little bit easier for you to read.
okay.
Okay.
So
Elevation
elevation.
and interior.
So I'm gonna say lead one. So it's that lateral
You're saying one or V,
elevation.
like V1 or one?
Uh, top left. So
Okay.
one, it looks like because if we're looking at our baseline, it is slightly elevated.
Yeah.
Two looks fine. Can I scroll down at all?
Uh,
So would this be
Actually, here.
anterior lateral?
Yeah, hold on. Open image
Mhm.
and new tab.
Because anterior is elevated too.
All right,
So P1.
there.
There we go. Okay, cool. Yep.
One,
And I'm
two,
gonna
three,
agree.
four.
Not that you're asking, but one, two,
They're all
three is
elevated.
all elevated. Four.
So, and then, okay. So anterior lateral
And then
with
five
inferior
matches. Does it? No.
with inferior reciprocal changes.
Okay, good.
That's
So
what I would
let's
say.
Focus on that one. Yeah, there are inferior reciprocal changes. These are ST depressions. Okay. Now, where did you see the elevation?
Um, lateral and anterior.
Okay. Show me which laterals.
Lead one.
Uh-huh.
Um,
Oh,
yep,
actually, yeah,
right
yeah. It's
there.
just very slightly, right? Yeah.
Would you say that's elevated? Because it looks elevated to me. I
Yeah.
just started top left and started working my way
It's
through it.
Yeah.
very mild.
Don't look at top left and working your way through. Look at it
Hmm.
by zones. Okay.
Zones. Okay.
So 2-3 AVF, you see the depressions. You see lead one looks a little bit fishy. What
Uh-huh.
other
Hmm.
leads are in the left lateral?
6 and 5.
AVL 5 and 6.
AVL. AVL 5 and 6. All right, we'll do 5 and 6 first. How do these guys look?
Massive elevation.
Yeah. ST segment elevation.
Yeah, this is starting to rise. Oh, V4 is starting to really get up there as well too.
Hmm.
Okay. The anterior, oh, there we go. Yeah, all right, so the anterior leads look all weird. Do you see
Hmm.
how this one has an elevation?
Yep.
So
And this one too?
inferior.
All right. This is actually an anterolateral STEMI.
That's right.
Yeah.
I got it.
Here's the other
Yep.
clue. Do you see how the QRS is super tiny and the T wave looks gigantic by
Hmm.
comparison?
Yeah.
Yeah, if you can fit a QRS in here, this is an early finding.
Oh, okay.
The reason why you might hesitate a little bit for V3 and V2 is that the QRS spikes. Have you guys heard of early repolarization?
But yeah, I've heard of it.
Yeah,
Yeah,
that's
but I
it, the
can't
QRS
talk about
spike.
it.
Usually the spike they have to be big enough to almost touch the other lead tracing. But you end up with kind of a QRS that looks almost like this. It's like the heart overshoots to recover.
Okay.
But you need a really big QRS spike for that. This is not it.
Okay.
This one looks almost like an early repole, but this is just way too big. I can't ignore it. All right. So this is kind of a more subtle one, but this would tip me off.
Yeah, that's what I looked at. The
This
V1
would tip
was
me off. Yeah, so good. And then
there.
the depressions would tip me off. So if I saw these depressions and I saw this finding, automatically V1 and then reciprocal changes 2-3 AVF, that's enough criteria to call a cardiologist and they'll come over. The icing on a cake is the hyperdynamic T waves. They look like they're going to consume the QRSs. This one, right? See how just massive this is compared to the
Yeah.
QRS. See how massive this is compared to the QRS.
Yeah. All right. I can't
And
even barely like AVL. I can't really even see it. The
yeah,
QRS.
right. It's so small. If you can fit the QRS in the T wave, that's a hyperdynamic T wave.
Okay.
Okay. All right. So this would be a let's see, anterolateral STEMI with reciprocal changes in the inferior leads.
Right.
Good job, you guys.
This is, I don't know, kind of fun, I think.
Yeah, once you know what you're looking at, it's like,
Yeah,
oh, okay,
yeah,
I get
right.
it now. I
I'm
get it
like,
now.
fuck, I want to use this in practice, but
Yeah. All right, let's look at this one.
all right. Let's see.
Let me know if you need me to isolate this from the page.
What do you mean by that?
Uh,
So
oh yeah, we can
elevation
see
to
everything here. Okay.
1, 2. So
Yeah.
yeah. I would.
Inferior.
Man, this is everywhere. It's just depressions in anterior and right. Is this inferior lateral? Wait, hold on. Let me check
I'm
the
gonna say I
words.
agree on
Inferior lateral.
inferior. And
But
the
if you look
lateral,
at
what are you saying?
V5, yeah, V5 and V6, they're
Yeah, yep,
kind
I'd
of
agree.
slightly elevated too,
Elevated
with
to your.
reciprocal changes
Hmm.
in uh anterior and even AVR.
And then, yeah, what did you say? Inferior lateral? Yeah, I'd agree with that.
Yeah,
Yep.
inferior
Not that you're
lateral with
asking,
reciprocal
but
changes. Is that right, Gordon?
then,
Yeah, inferior lateral is a common combination, right? So let's look at
Ooh.
this by zone. Let's look at the left lateral. So this one looks normalish. This one looks
mhm,
normalish. Oh boy. So here's the baseline,
Yeah.
and here's the ST.
elevated.
Yeah.
Hmm.
Okay. Here's the baseline. Here's the ST. Yeah, it's
Mhm.
elevated. This part looks normal. Let's look at, oh, and since I'm on V4, let's continue the anterior leads, right?
Yeah.
All right, this looks a little bit weird.
Yeah.
Mhm. But and then
Non-specific. Oh
Big
boy,
depressions
here
in
we go.
V1
Here's a
and
big
2.
yep, there's
depression.
our depressions.
Here's a big depression. In fact, shoot, on AVR, you have a big depression
Yeah.
as well, too. All right, how about the inferior leads? Here's the baseline. Oh, that's a,
Elevation.
yep,
Hmm.
same thing. Baseline, high ST. Baseline, high ST. All right, good. So having done that, here, just look at it again. See if you can identify the ST elevations and ST depressions. Now
Uh-huh.
that we've kind of collectively pointed it out, I want you to cement this in your head. All right. Looking at zone by zone, you can identify this one pretty easily now, right?
Yeah.
Yeah. So inferior lateral ST elevations and anterior lead depressions. Nice.
Would you say anterior and right then, or like the AVR, you just don't even pay attention to that
A lot
kind
of
of thing?
times people don't pay attention to the AVR, right? The
Okay.
joke is that if you have an AVR, that means the machine's working.
Okay.
Mostly because it's so far out there. It's so far
Yeah.
just out on its own. Remember that sphere diagram?
Yeah.
And so much of the heart is at the left side of the chest anyway. All the piping goes towards the
Gotcha.
left.
Okay.
Yeah, that's why. Let's see. Ba, 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 ba. All right, let's do one more. Close your eyes one more time.
All right.
Boo. Okay, all right, let's do this.
Okay.
So elevation in two,
Anterior.
3.
What is that? And
Is V2 and V3? Is there a drop? You're missing something or like prolongated? It looks
yeah,
funky, but I don't
looks
have the
super
word.
weird.
All right, I'm gonna walk through this with you
It's a
guys.
depression?
Not quite.
No?
You almost have to discount this. All right, do you see how lead 2 shows up multiple times down here? This is the
Hmm.
Oh
rhythm
yeah.
tracing. Okay. These are normal QRSs for the patient. This is PVC. This is a
Oh,
PVC.
gotcha.
These are probably PVCs also. So that makes it so everything vertical to this, you almost need to throw out.
Oh, okay.
Okay. So technically, this is not a good quality EKG.
Okay.
If you guys handed me this, I would say,
Take it again.
yeah, take it again only because I can't read 1, 2, and 3.
Right.
Okay. And you really just need to like offset by a few more seconds, honestly, and then you'll get some
Gotcha.
usable information. All right. So knowing that, this is hard to read. At least in the inferior leads, we have this one that we can use. This AVF looks okay. And left lateral, we can't use this one. This one looks okay, all right, in terms of like ST stuff. They look all
Yeah.
right. The other left laterals, we can use this beat and this beat. So this one, oh, this T wave's starting to get huge.
Yeah.
Okay. And then for the anterior portion, we can't use this beat, but we can use this one and this one. All right. Oh, geez. Hey, you think this T wave can eat the QRS?
Yeah.
Yeah. So
What's
this
the
is
term for
a
that? Dynamic?
hyperdynamic,
Hyperdynamic.
hyperdynamic T wave. Okay. So this is an anterior STEMI. This one's hard. This one's
Yeah.
hard to read.
See, all the little rules of thumb don't work.
Yeah, yeah. This is where if you have an EKG without the rhythm strip, it's almost impossible. This is why the EKGs contain rhythm strips.
Gotcha.
Yeah, lead 2 and V5 are the common ones. And so if something looks weird like this, your first port of call is to look down here. All right, which beats can I use? And then throw
Okay.
out the PVCs because they're not
I
going
didn't
to be
even
helpful.
realize that bottom part is I noticed it on all the previous ones, but I didn't realize that was like the tracing
Yep.
to
Yep.
go
This is
off
why
of.
they include the tracing so that you can see one lead across all this time,
Yeah.
and then throw out the garbage. Yeah. All right, let's see if we're right. Hyperacute anterior STEMI. Yay! Nice. Okay. Cool. Yeah. This one's tricky. All right. You guys want to do one more?
Sure.
Sure.
Okay. All right. All right. Close your eyes.
Gotta send me the recordings, Gordon.
The recordings are gigantic.
Oh,
I'll post it on YouTube or something.
okay.
All right. Cool. All right. Here we go.
Comment, like, subscribe.
Yeah, hi
Yeah.
YouTube.
Right. Jeez.
Follow me on Twitch and all my other socials.
Yep, yep. Yeah,
Uh,
yeah. We can do some real-time like EKG readings on Twitch.
Yeah. So inferior
Yeah, while I sit in
elevations
my furry
right away.
costume.
Inferior
Stop
and
using your fancy words. Right? My fucking notes. I'm sure you're 2, 3. Yeah,
see.
no, I agree.
Looks like
2, 3,
there's
F.
anterior elevation as well. Right. And oh. Uh
Yeah. In-
and maybe
Depressions in
very, very slight.
lateral and the ABL.
All right, good. Let's
Yeah.
do this
And
in
then
parts.
very
Versus
Ian,
slight,
five,
possibly in V5
6.
and 6.
Ian, sell me on the depressions. Convince me
Um,
why those are depressions.
in the ABL.
Yep.
So you're looking at your baseline,
Uh-huh. Yep.
and then your ST segment is lower than your baseline. So after your
Yep.
QRS, that's
Yep.
why I call those depressions.
Good. Now, in terms of left laterals, do you see any other changes?
Left.
And one, um, it's ever
Not,
so slightly
yeah.
depressed, and that's
This
why I
is
didn't say
frankly
anything
normal.
about that because it's
Yeah.
okay.
Yeah.
When it's like
And then
less
what
than
about 5 and
when it's
6?
less than half a millimeter, it's like it's not
Doesn't
really.
really count.
Yeah, and there's like a slight curve down too. I wonder if there's like some respiratory
Oh,
artifacts.
okay.
And
Yeah.
5
You know,
and
because like
V5
sometimes
6.
if
and
someone's breathing heavily, you can see like the baseline ends up with like as a sine
oh,
wave.
okay.
Yeah. All right, so this one is essentially normal. How about the other left
Okay.
lateral leads, V5 and
It's like
V6?
That looks like
very would you say that's a very slight
Yeah.
depression,
No,
right?
elevation.
Oh,
no
elevation.
elevation.
You
Yeah,
see how
right
there's,
where the mouse
yeah.
is. Yeah.
So for this guy, his heart, because you're going to talk to me about the inferior STEMIs later, right? So this guy, his heart, like this inferior zone that's affected, is starting to reach out to the left lateral.
So even though they're the same zones, they can be like depressions in
Yeah, this one's
elevations.
kind of weird, but if you think
Okay.
about it, let's see. Here is the AVL. Here is V6. So this is probably for this EKG, it's probably affecting this area. And you see the
Okay.
reciprocal,
Gotcha.
a little bit further away.
I thought it was like at the start of the ST segment, it's like at the end of the QRS, it's a little bit lower. That's why I thought, even though it looks like, I mean, it's an elevation, but I thought
Yeah,
because it
just
started
a
low.
little
Okay.
bit of an elevation. If you let this go
I guess I was
long,
looking at
this will
V5
start
more.
pushing up.
Okay.
Yeah. Okay. All right. Good. So this is a definitely an ST depression AVL. And then Rinston, tell me about what you saw in the inferior leads. Convince me that they're ST
Uh,
elevations.
well, there's elevations in 2, 3, and ABF. I mean, like we've discussed previously, it's significantly higher than
Mhm.
the baseline.
Yep.
And then the ant uh there's a no, I mean, yeah, so it would be
Yeah.
inferior.
Yep. Yep,
inferior
so this
STEMI.
is like maybe 1.5 millimeters up. This is about 2 millimeters up. This is about 2 millimeters up as well too.
Okay.
Yeah, so inferior ST elevation, left lateral, reciprocal changes.
Okay.
Nice. Inferior STEMI.
Mhm.
Okay. All right. It's 7:55. It's been about 2 hours, and we covered a lot of ground.
Great.
Yeah.
Yeah, it was good information. It was fun.
Yeah. Yeah. I hope it was fun.
Yes,
What I
thank you.
can, no, no problem. All right. What I can do is I can save this as an image and send it to you guys.
Sure.
Okay. X, my notes look like shit. I circled things wrong.
Yeah,
That's just
mine looks bad too.
I looped, what is that, 1, 2, 3 and AVF together, and I was like, oh no, it's one AVL,
Yeah.
then 5 and 6.
I
So
looked AVR and
yeah,
V5 and V6 together. I was like, oh shit.
Oh man. Okay. So honestly, practically for you guys, um, uh, this is probably useful. If something's super tachycardic and super
Yeah,
bradycardic,
that's pretty cool. I
that's
never thought
good
about
for
that.
your eyes to pick out. Okay, look up
Mhm.
some examples on the internet. If you can remember this chart here, this is critical. All right, because this will
Yeah.
show me, this will show you like where all the zones of the heart is, and you can start training your eyes to look at EKGs in chunks. Okay. Because if you can be the early warning detection system, you will catch these faster than the attending will. All right, cool. Guys, this was a lot of fun.
Yes,
Yes.
thank you. I appreciate
Yeah,
it.
maybe in
Yes,
the
me too.
future we can do some other stuff, like if we want to go over certain physiology, what have you.
Yeah, for sure.
Yeah.
Always up to learn from you, Gordon.
Oh,
Yeah.
thanks. Yeah, those will be a
Yeah.
lot shorter, right? Because the EKG just covers so much information. So
Yeah.
maybe like, I
Mhm.
don't know, 15, 20 minutes, snippets here and there. I'll just make ugly handwritten diagrams on a computer like this time.
No.
Yeah.
And I know it's been 2 hours of your time, so thank you for that. Thank you very
Yeah.
much.
Oh,
I do
yeah.
appreciate it.
Hopefully your lecture goes well, since you've
Yeah.
used us as guinea pigs, but it was
Yeah,
great.
all right. Well, if you could
Wonderful.
teach a monkey to do it, you could
Yeah.
teach med students, doctors and trainees, whatever. If I
I'll,
get it, I'm over here like, ugh.
All right, cool. This is awesome. All right, cool. I'm going to stop the meeting, and
all
then
right, sounds
once I
good.
have everything posted, I'll let you know.
Yeah, let me know if
Yep.
you post a video or
Yeah.
whatever. So
All right.
I'll share
Awesome.
that with Jennifer. She'll get a kick out of it too.
Okay, good. All right. It was a lot of fun seeing you guys.
Thanks.
All right,
Yep.
good
Yep.
to
Take
see you,
care.
Gordon.
Yep. Bye.
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 Like and subscribe.
Yeah.
How do I do this?